All right, we're screen sharing, we're unmuted, we're recording. Perfect. I think the sound didn't go up. Okay, we are recording. Great. All right, good morning, everybody. Welcome to Coplow Rounds on December 10th. Oh, goodness. Give it 1 second. Good. All right, great. So I am Dr. Kelsey Brown. I am one of the pathologists here at Coplow, and I am taking us through the first two cases. I can advance my slide. There we go. So the first photo, I do not have a gross image, but we have this lovely clinical image provided by the clinician. Should we thank for that? So this is going to be a conjunctival sample, so not a full globe, from a horse. This is a 30-year-old male castrated Arabian horse. And the history we provided was that there was a ventral conjunctival swelling slash mass on the right side, which this photo here does show kind of this vague swelling of the ventral conjunctiva. And maybe we kind of have the leading edge of the third eyelid there kind of peeking out as well. And they said that this has been going on for about 3 to 4 months. And the other eye is normal, and we don't have any other systemic signs that were provided in the history, at least. So we will move over to our histo. Looking at our grossing notes, we received 2 pieces of conjunctiva. We had a hard time orienting them grossly. We said one may have cartilage in it, so we wondered if we had gotten a little bit of the third eyelid with these samples. And so I'll pop our first set of tissues on. Let's see. So we do indeed have a little bit of our third eyelid here. So here's our third eyelid cartilage, and then here's the gland of the third eyelid. And then surrounding that, we have this kind of orbital adipose tissue, this fibrovascular stroma, which is all normal there. And then we have some conjunctiva as well. And we can see that there's this area where it's just more purple. So there's more cells infiltrating the conjunctival substantia purpura. It's surrounding the gland of the third eyelid. Maybe there's areas where there's kind of a blurring of the gland of the third eyelid. So there's maybe some infiltration of the gland itself as well. And as we look at low power, we can kind of vaguely draw a line around this area of increased cellularity, but there's areas where maybe it's not quite as distinct. So it's not a particularly well demarcated cellular infiltrate. And there's no capsule around it. In some areas where we're at low power, we can also see these kind of more densely purple areas. So maybe there's something different happening there, you can at least say. All right, so let's go a little bit closer and check these guys out. So I'll go even one closer. So we have this relatively homogeneous population of cells. So this is a neoplastic infiltrate. And in a lot of areas, it's kind of hard to discern a particular pattern that they're making. Maybe some areas they're kind of this plump, more polygonal shape. In some areas, they look a little bit more spindle shaped. In this particular area, I have a hard time making out that particular morphology, but we'll zoom around. I can show you different morphologies for this cell type. And in this particular field, they're also not really making any distinct patterns, kind of just these solidly cellular areas. They don't have very distinct borders. It's a little hard to say exactly who these cells are. We can make out these round to oval nuclei. They have this more coarse chromatin. In some areas, we call this vesiculate, where it almost looks like little kind of soap bubbles within the nucleus. And they have one, maybe sometimes 2 pretty distinct nucleoli. And in this particular field, we can make out some mitotic figures. And zooming around, there are some rather mitotically active areas. So this neoplasm had a mitotic count of, let's see, 96 per 10 high power field. So that's a robust mitotic rate. And landing on some of those more densely cellular areas, within this neoplasm, there's also these large clusters of small lymphocytes. These do not appear to be neoplastic. They're kind of distinctly separate from the neoplasm itself. Rather, just it's a inflammatory infiltrate possibly called in by this neoplasm. It's just rather robust. And as we move closer to the gland, we can see there are indeed areas where the gland is also being infiltrated by this neoplastic population. So here are some normal native glandular acini, and then we have these neoplastic cells that are replacing and kind of dissecting between the glandular lobules. So from this particular sample, it is a little bit hard to say exactly what this neoplasm is. It kind of just looks like a poorly differentiating neoplasm. It's exhibiting multiple features of malignancy. There's some cellular and nuclear atypia. There's a robust mitotic rate. So we at least can say this is probably a malignant neoplasm, but hard to make many more conclusions based off of that sample. So I'll move to another slide where, again, we have a little bit of conjunctiva. So here's our conjunctival epithelium, our substantia propria, and we have this neoplasm. And let's see if I can find the right one as we move around. Again, similar areas where kind of this more solidly cellular pattern. It's not very distinct. As we move out to the periphery, we get to these areas where these are making somewhat more distinct patterns. So these neoplastic cells are now lining these channels. You can see all these channels. They're mostly filled with just clear space, so they're empty. Sometimes they have these little small lymphocytes within them. And it's a pretty consistent pattern that they make in this particular region. Going closer, these are where these cells begin to take on a more spindle-shaped morphology. Oftentimes they kind of bulge out into the channels. We call this hobnailing. It's kind of the colloquial term for that. Closer. And there's other areas where maybe they make these more kind of smaller, thin clefts. It's still kind of somewhat reminiscent of vascular channels. And one last focus that I dotted because I knew I was going to have a hard time finding it. You can ignore this scratch mark in the cover slip. That's an artifact. In the substantia propria, so here's a normal lymphatic vessel. It's just an empty vessel. It's lined by this very thin, well-differentiated endothelium. And as we track along that lymphatic, then we start to pick up these neoplastic cells again that seem to be kind of within or expanding the wall of this lymphatic vessel. We can see it more kind of tracking along here. Maybe we pick up the normal lymphatic again. So kind of interesting, it's tracking along the lymphatic. So at this stage, we had said that definitely this is a malignant neoplasm. It's making these vascular channels or channels reminiscent of vascular channels that are usually empty. We don't see any blood in those channels. And we also have areas where we have this kind of lymphoid infiltrate. So we ended up calling this an angiosarcoma with the differentials of a hemangiosarcoma, so a neoplasm of wow, I can't think of the word. Versus like a lymphangiosarcoma, so like a lymphatic. Yeah, so vascular endothelial origin. So hemangiosarcoma versus lymphangiosarcoma. Apparently, it's still early for me. So we ended up reaching out to the good folks at Cornell who had IHC that could help us further differentiate these two neoplasms. We performed PROX1 and LIVE1, LYVE1, which are considered specific for cells that line the lymphatic vessels, so lymphatic endothelial markers. And I do not have the IHC slides to show, but it was reported that these neoplastic cells showed robust and diffuse labeling for both PROX1 and LIVE1, which supports that it's likely of lymphatic endothelial origin. That would allow us to make a diagnosis of lymphangiosarcoma for this neoplasm. So I will move over to our diagnosis, lymphangiosarcoma. And this is a rather rare neoplasm. Typically, when we have an angiosarcoma kind of around the eye of a horse, oftentimes it's a hemangiosarcoma, usually due to chronic UV light exposure. So in this case, this is not a hemangiosarcoma, but lymphangiosaarcoma, which there are a handful of case reports in the literature of ocular and periocular lymphangiosaarcoma in horses. And one did affect the third eyelid, which we certainly have evidence of that here. Looking through our own database at Coplow, we only have a few cases that we called angiosarcoma, and this is the only one that we kind of more definitively concluded as a lymphangiosarcoma. So it's hard for us to kind of draw many conclusions in terms of prognosis, but at least in the literature, some of them were associated with more widespread metastases, and some were very locally infiltrative and hard to resect. So we provided that information for this case. At the very least, we do have pretty poor distinction of the neoplasm. It does appear infiltrative, so recurrence is certainly possible. And then, if possible, staging would be appropriate in this case. It's possible that there could be metastatic potential for this neoplasm. And this is one where we did request follow-up if there is any in the future for this horse. We're certainly interested in having close follow-up on this one. And that is it for that case. Move on to my next one. So this one is actually a globe. So this is the globe from a 2-year-old female spayed beagle mix. And we got a nice history for this one. So this globe was enucleated due to glaucoma. Gonioscopy was performed on the other eye, and it showed a closed iridocorneal angle. So it sounds like there was suspicion of primary glaucoma in this particular eye. They did have this eye on dorzolamide and timolol as well as latanoprost. They noted mild evidence of optic nerve atrophy on their fundic exam. And then during enucleation, they noted abundant vermiform structures visible at each extraocular muscle insertion and extending between them along the sclera. Very lovely description. So here is our globe. On the left here, this is the globe before it was hemisected. The cornea is pointing up top. We have our optic nerve at the bottom here. And then this is just the sclera that we're seeing. And we can note those kind of vermiform structures within the sclera. And there's a ton of them. It's a bunch up here. It's quite pretty. And then here is our hemisected globe on the right with cornea up top, optic nerve at the bottom. And a little bit hard to make them out here, but maybe we have these kind of white dip dots in like next to the sclera and the extra scleral tissue. And maybe along here too. Again, it's a little bit hard to make them out. And then looking at the actual ocular structures themselves, they look relatively normal grossly. We said there's maybe a shallow cup of the optic nerve head. It's a little hard to appreciate here. Okay, so get rid of that one. For globe. Let's see. Starting with our subgross. Okay. So cornea is up top for the subgross. We have our optic nerve in the back. And again, our kind of intraocular structures are relatively unremarkable, especially at this power. So we will look at those a little bit more closely. You can see within our sclera and our extrascleral connective tissue that we do have these kind of circular structures. Sometimes they're a little bit more oval, and it does seem like there's maybe some sort of cellular infiltrate associated with those structures. And they're rather extensive. Kind of go around. Here's more of them. A little bit more closely. So now the globe's been rotated. The cornea is to the right. Posterior segment is going to be to the left. And we'll just start with those guys. They're very cute. So the clinician's suspicion was correct. These are vermiform structures and that they are little nematode worms. Go around to show them. There's quite a few of them, and they're quite well preserved, so we can actually look at them and describe their features a little bit better. So on cross-section, they have, for the most part, a somewhat smooth cuticle, but there are areas where we can make out these little kind of bumps right here. So we have these longitudinal cuticular ridges, and they're somewhat evenly spaced. You can see, I feel like maybe that was not the best example. Let's see if I can find. Yeah, they're kind of indistinct, but every so often we can kind of see these little little ridges. They have a pseudocoelom, so this clear space within here, and they have a polymyarine coelomyarine musculature. So they are lined by multiple muscle cells, and oftentimes they'll extend into the pseudocoelom. So we can kind of see areas where there's extension of that muscle. And then they have a digestive tract as well as a reproductive tract. And in some areas, let's see if I can find a good area. That reproductive tract contains microfilaria. So this is a uterus that contains all of these little microfilaria. So this is a filarial nematode. Within this location, this is all most consistent with Onchocerca, which is what the clinician also suspected. This dog, let's see, lives in Arizona. So that's a great place for a dog to develop onchocerciasis. And in this case, it's just rather extensive, and it seemed to be a somewhat almost incidental finding on surgeries. That was kind of neat. Then that brings us back to this dog having glaucoma, so we need to investigate that more closely. So that prompts us to actually look at the iridocorneal angle, where we do have a kind of iris-like tissue. It crosses the iridocorneal angle and it contacts the termination of Descemet's membrane right here. So this is consistent with goniodysgenesis. And we don't really have much evidence of a ciliary cleft or trabecular meshwork behind that iridocorneal angle. I can go around. It's a pretty consistent finding. This is a nice example. This one, we do have some melanin-laden macrophages scattered in the anterior chamber here, but we still have kind of a similar finding. So Descemet's kind of wraps around and it contacts this slab of iris-like tissue. And then we can go back. This one didn't have super impressive evidence of glaucoma. The optic nerve head wasn't particularly atrophied. Other thing we want to look for that histologically clues us in that glaucoma was present is atrophy of the ganglion cell layer of the retina. And there are segments where maybe we do have decreased ganglion cells. As we kind of travel around, sometimes we pick up one or two, but there are decreased numbers. So this is one where it's not super impressive histologically, but there is evidence of glaucoma, and we certainly have reasons to suspect glaucoma would be present with this closed angle. So kind of a fun twofer case of goniodysgenesis and then onchocerciasis. The clinician did wonder if, due to this worm burden, if these worms could have also disrupted aqueous outflow from the sclode and contributed to glaucoma, which we did ponder as kind of an interesting thought, especially because they are somewhat close to the sclerovenous plexus and kind of this aqueous outflow path. However, we do see normotensive globes that have this distribution and burden of worms. And then also we do have a super closed angle. So in this case, we were pretty comfortable saying that this is glaucoma, likely just due to goniodysgenesis. So a primary glaucoma with kind of these incidental, quote unquote, onchocerciasis. So I will move to diagnoses. And so onchocerciasis, this is a great place to find them. Some of the sclera, kind of extrascleral connective tissue. At least in the US, there's a somewhat specific region that we tend to see these cases develop. Utah, California, Nevada, Arizona are great places. There are some places in kind of more European countries where it's also diagnosed. And there is a report that actually speciated a lot of these onchocerciasis cases and found that the most common species is Onchocerca lupi. And yeah, in this case, likely it was not super important in terms of clinical science, but more just kind of a fun finding for us at least.
What's interesting about the geography or the
Mhm.
geographic distribution of these cases is that they're super localized.
Mhm.
So even in those areas that Kelsey mentioned,
Mhm.
you can trace them down to an enclave in Southern California.
Mhm.
They're kind of around Salt Lake City. And then I think the first group of cases that we described were cases from Greece and
Mhm.
Thessaloniki in Greece.
Mhm.
And they all have this type of environment. It's like a dry environment with like a lake bed or body of water around.
Mhm.
It's just pretty cool to think how, hyper localized they are.
Mhm. Yeah. Okay, great. With that, I will hand over the scope to Dr. Shaw.
Good morning. Hello. All right. The first case is a 15-year-old domestic cat, a Manx, um, with a chronic history of swelling and possible pigmentation, period. They don't really explain of what. And then sudden onset of conjunctivitis and possible hypopyon. So they say duration of problem was weeks to months. The other eye is normal, and apparently the rest of the cat is normal too. So here's the globe. The cornea is always at the top, although sometimes it's hard to tell. So we said that the globe was ophthalmic when we grossed it. And basically, the cornea was opaque. And then when we hemisected it, it was essentially filled with this tan solid material slash mass. The lens is right here and it's quite opaque. So there is a cataract. And that's about it. Whatever is happening inside the globe does extend into the cornea and through the sclera, at least in this area right here. And this is the third eyelid, so that would be ventral to ventral medial. So, all right. So here's the globe. Here is the back of the globe, and here's the optic nerve right here, and the connective tissue around the optic nerve. So as we move forward into the globe, the lens that we saw grossly is sort of in this area. And then here's the cornea at the front. And then what we can see is the globe is essentially filled with this tissue that has some purple areas and some pink areas. The purple areas are densely cellular areas where the cells are somewhat still viable or were at the time of fixation. And then the pink areas are areas of necrosis. So at this point, you always need to figure out, is this inflammatory or is this neoplastic? And there's the third eyelid, as I pointed out. All right. So we'll start at the front. Here's the cornea. The corneal epithelium is hyperplastic and keratinized right here. And then the stroma itself is fibrotic and vascularized. Descemet's membrane is separated from the posterior aspect of the cornea. Here it is, and it's actually discontinuous, so it is ruptured as well. There's another end of it right there. So it's multifocally ruptured. And then as we move back, we can start to appreciate how densely cellular this tissue is. To find the best spot, I'll just go right here. So from a relatively low magnification, the cells are not really forming any structures. They're also not forming like granulomas, for example, which would be looking for inflammation. And as we get a little bit higher mag, these cells are really big. They have pretty big nuclei. And they're fairly monotonous. So this is a population of neoplastic cells. We have some smaller cells to compare with that are probably neutrophils, and then you can compare this nucleus of this neutrophil to how big the cells of these neoplastic cells are. The cell borders of these neoplastic cells are not necessarily that distinct, but my gut feeling is that this is a round cell neoplasm. And we have a pretty significant, well, we have some anisocytosis, which is variation in cell, and anisokaryosis, which is a variation in nuclear size. And then some of them might be multinucleated, like this person right here. And then as we look around, we can also start to pick up quite a few mitotic figures. So here's one here. This might be one up here. So as we look around, this is pretty consistent across this entire globe in areas where the cells are less healthy, probably because of ischemia. Their morphology is a little bit different, but this is a mass that essentially fills the globe. In some areas, we also have more significant populations of smaller cells with smaller nuclei, with more condensed chromatin, and these are likely inflammatory lymphocytes. And let's see if we can find that lens. It's back here somewhere. Okay, here's the lens. So what we have illustrated right here is lens capsule wrinkling, which is the hallmark of a hypermature cataract. And inside, we should have nice, solid, orderly lens fibers, and we totally are lacking all organization. So these lens fibers are liquefied, and all of this dark purple granular material is mineral. So we have a pretty advanced cataract. And then also, as we go higher, Meg, some of these smaller objects in here are probably inflammatory cells. So there's lens capsule rupture as well. So some of these cells in here are neutrophils. And the lens capsule is not completely sampled. So I don't know if we sampled a site of lens capsule rupture. Maybe right here, actually. Yeah, maybe. I don't know. Anyway, so I assume the lens capsule is ruptured based on those cells that are inside the lens capsule. As we move back toward the back of the eye, the retina is no longer really identifiable. So here is the optic nerve. So here's the optic nerve head. And we just have more of that neoplastic tissue inside the eye. The choroid itself is expanded by a lot of inflammatory cells. And actually what we have here is a lymphoid follicle with a germinal center where we have larger cells with more slightly abundant cytoplasm surrounded by a dense rim of smaller lymphocytes. So that's a good lymphoid follicle there. So so not only do we have a very extensive, significant neoplastic process and mass in this eye, but we also have significant inflammation in the parts of the uvea that are still recognizable as uvea. So to recap, we have a really extensive, significant round cell neoplasm in the eye of a cat with a duration of at least months. We have evidence of an advanced cataract with likely lens capsule rupture, and then we have significant uveal inflammatory infiltrate. And the round cell population is consistent with lymphoma. We don't actually have any immunohistochemistry to confirm that, but it's pretty much understood to be lymphoma in my mind, at least. And so I called this chronic uveitis-associated lymphoma, which was formerly known as post-traumatic lymphoma because many of the cases have evidence of trauma, in this case, probably lens capsule rupture and an advanced cataract. So essentially this is a lymphoma that develops in the eye. So it's a primary, or it's a solitary, well, it's an ocular lymphoma that can be solitary, i.e. confined to the eye. The prognostic sort of features that we look for in this is whether the margins, the surgical margins were clean, including the surgical margin of the optic nerve. And in this case, those neoplastic cells did not extend to the optic nerve, to the cut end of the optic nerve. So that is what we know. It's probably possible for these to actually metastasize away from the eye via lymphatic or blood vascular system, but I think that's relatively rare. I think more often they extend locally when the margins are not clean. So we assume that this type of lymphoma develops in an eye that is chronically inflamed, so has chronic uveitis, hence the name, chronic uveitis-associated lymphoma. I also want to point out that not all cat eyes with chronic lymphoplasmacytic uveitis will go on to develop this disease, this neoplasm. I don't think we understand at this point. We definitely don't, nor will we possibly ever understand the prognostic, the reasons why some eyes go on to develop this and some eyes don't. In some cases, it could be the traumatic aspect of it with significant lens-induced uveitis due to cataract. So there we go. All right. Next case. This is a 9-year-old miniature schnauzer. Well, they didn't tell me it was miniature, but I'm assuming it's a miniature schnauzer. They say diffuse corneal neovascularization. There we go. Diffuse corneal neovascularization after having a melting corneal ulcer, which healed with severe residual keratitis. Um, Possible recent rupture and pain starting the last day or two. This dog is also diabetic, and has a diabetic cataract or possibly bilateral diabetic cataracts. Yes, bilateral. And the dog also has high triglycerides. So that's the perfect miniature schnauzer for us, a diabetic miniature schnauzer with high lipids. So what we have here is, as always, the cornea is at the top. Go away. Ah, everyone saw the answer. I'm done. Anyway, all right. So, oh gosh, okay. The cornea is opaque. Sorry, I'm a little bit too twitchy apparently. Here's the lens that is also opaque, and it has this interesting dark red rim. I'm not sure what the significance of that is. But any opacity in the lens essentially means there's a cataract or cataractus degeneration. And then really all chambers of the eye are filled with this off-white to dark red to slightly hamburger pink material to tan. So this is gross looking, grossly, I will say. And if this dog had different circumstances explained in the history, I would be thinking about something like contaminated traumatic perforation, where there might be bacteria in the eye or something like that. However, the diabetic miniature schnauzer with high lipids or triglyceridemia, hypertriglyceridemia, has this particularly unique disease that develops. And this is a decent case of that. So let's go to the slide. All right, this slide is embedded sort of crookedly in the cassette because of how big it was. So here's our cornea here. This is the anterior chamber and it has a lot of red stuff in it, so that's red blood cells or hemorrhage. Here's our lens that's looking a little bit irregular. The wrinkles are artifact, but we definitely have a tinctural difference between right here, and that is liquefied lens fibers right there. So that is one of the hallmark features of cataractus degeneration. The iris leaflets are a little bit hard to make out, but you can see this sort of streak of pigmented tissue there. So that's one iris leaflet on one side, and here it is on the other, and here's our ciliary body. As we move back, here's all that pink stuff that we saw grossly. And this stalk of tissue here heading up into the globe is probably the artist formerly known as the retina. And then there's a little bit more purpler areas, so that might be more dense inflammation there. And then there are the telltale blue dots, which share something important or highlight something important. And here's our optic nerve. So let's go ahead and dive in there. So here's our cornea. We didn't get it all quite sampled on the slide, but just in this area, you can see that the corneal epithelium is hyperplastic with some reedy ridge formation. And then the stroma, much like the other one, is also a little bit disorganized, fibrotic, and vascularized. They mentioned this dog had a corneal ulcer, a melting corneal ulcer, which sounded like it had healed. And what we have here are islands of corneal epithelium that are sort of embedded within the stroma. And that is one of the nicer features that we can use to confirm collagenolisis or a melting corneal ulcer is when the epithelium kind of drowns in the liquefied corneal stroma. The other possibility for these are reedy ridges caught at another plane of section, but I'm not quite sure what they are. But anyway, the epithelium is also pigmented, so we've got some pretty significant corneal disease. And as we move back into the eye, so here we are in the anterior chamber, we have a lot of red blood cells. So that's the hemorrhage. So there's been a lot of hemorrhage into this eye. And then the other significant population that we have here are these large cells that are polygonal, and they have abundant, finely vacuolated cytoplasm. So these are lipid-laden macrophages. So remember that this dog has high triglycerides in its blood, and we have significant evidence of, well, hemorrhage in the eye. And when you have a lot of lipid that's floating around in your blood, and you bleed into your eye, that means you have a lot of lipid in your eye, and this incites quite a significant granulomatous response. In some cases, in particular, in these diabetic miniature schnauzers that are hyperlipidemic. So this is this disease we call Xanthogranulomatous endophthalmitis. So endophthalmitis refers to any inflammation that's in the ocular chambers, so anterior, posterior chamber, vitreous, subretinal space. And xanthogranulomatous refers to granulomatous inflammation associated with lipid. And it often has lipid-laden macrophages, which is how this disease got its name. So here we are in the lens. Here's the anterior lens capsule. Here's some slightly still intact lens fibers, and what we have here are liquefied lens fibers right here. So these have lost all of their normal structure, and this is what led to the opacity in the lens. These are some lens epithelial cells that have undergone mesenchymal transition. So normally they're cuboidal cells that line the anterior lens capsule, and when they turn spindle-shaped and sort of start to migrate around inside the lens, that's epithelial to mesenchymal transition or fibrous metaplasia, and that's another hallmark of cataractous degeneration. The red coloring that we saw grossly is just not very dramatic here, but I think it probably has to do with either some interlenticular hemorrhage somehow, which would imply that there was lens capsule rupture, or it could also be, and here's a little tiny evidence of it. So when red blood cells break down, they release their hemoglobin, and in the process of breaking down all of their red blood cell bits, various products can actually leak through an intact lens capsule and sort of stain the lens fibers and accumulate inside the lens. So what we have here is a little bit of brownish stuff, brownish yellowish stuff. So this is probably hematoidin or hemosiderin, which has leaked through the intact lens capsule. Also, it's a diabetic cataract, and they are known for their spontaneous rupture. So there could be lens capsule rupture here somewhere too. Anyway, as we move back, the inflammation does vary a little bit. Sometimes it is a little bit more suppurative, as we have here. There we go. So there's some neutrophils mixed in with those foamy macrophages. So here's sort of a mix of foamy macrophages and neutrophils. Let's see if we can actually identify that as the retina, which I thought was the retina. Yeah, sometimes when the retina is detached and completely necrotic, the only thing we can hang our hat on is a line of blood vessels, because they actually maintain their structure much longer than the rest of the retina does. So I think what we have here is a sort of a congested blood vessel containing some degenerate red blood cells. So I don't think blood is flowing very well in that blood vessel. So let's go back here. Whenever we have the history of high lipid, high triglycerides, we always try to look for vascular disease to go along with that. And we've got two nice examples here. So we've got one little blood vessel here. The lumen has a single red blood cell right here. The wall of this blood vessel is very thickened by hypertrophied smooth muscle cells, and it also has some vacuolated cells in the wall. So these are probably lipid-laden macrophages as well. They look slightly different in the blood vessel wall than they did inside the eye. And then here's another vessel. I'm not quite sure where the lumen is. We do have one red blood cell here. So this might be the lumen, but it's a little bit hard to tell. But this wall is just effaced by these very large foamy macrophages. So this is some very nice examples of atherosclerosis. And that in dogs is often associated either with hypothyroidism or with, to be honest, diabetic miniature schnauzers. And other smaller breed dogs, maybe like Bichon Frises, maybe we see it. But anyway, I mean, atherosclerosis can develop in any dog.
Disease in general, but
Yeah, with
most common causes.
yeah. So anyway, we've got a very nice, tidy case here with all of the really unique features of a diabetic miniature schnauzer with high lipids. So
Is there any clinical work done, blood work prior to the submission that we know, or?
they say high triglycerides, and they knew the dog was diabetic. So All right. So there we go. Severe fibrinosepparative endophthalmitis with foamy macrophages suggestive of Xanthogranulomatous endophthalmitis, marked chronic intraocular hemorrhage, hypermature cataract that was presumably diabetic, and atherosclerosis, among other things. So those are the most important diagnoses. So, all right. Next up.
Right. I am Megan, and I have a really cool case for you that's very appropriate for the holiday season. And I wish I could credit the clinician for these lovely images, but you know who you are. So, this is a 5-year-old spayed female miniature Australian Shepherd. This patient's name is also very holiday appropriate. You'll just have to imagine it. So they say moderate blue thalamus and episcleral injection, mild diffuse corneal edema, and they note these diffuse floaty particles inside the eye, in the anterior chamber as particulate flare. There's hypermature cataract, and they can't see the posterior segment. Um, Interestingly, they note that I think both eyes ultimately developed cataract kind of acutely. There's no diabetes or anything mentioned in patient history. They did work the patient up, no diabetes. Yeah, apart from that, there's some maybe skin issues that the patient's on immunomodulatory therapy for, but not too much systemically going on. So, okay, let's get right to the fun part. So here is a clinical image of this dog. You can see that this dog has a blue eye. We've got that iris right here. And then there's kind of this like reddish flare, which implies maybe there's a bit of blood, and then all these kind of floaty particles. But it's harder to see on a still image, so let's hope that this works. It's snowing inside the anterior chamber.
Oh, yeah, everywhere today.
15, yeah. So you can see it's much better on the video. Thank you again to our clinical clinician for sending this. There are these floaty, glittery particles inside the anterior chamber. So that's pretty cool. All right, let's go to
I wonder if the reddish hue could also be
oh,
from being a subalbinotic
right.
blue eye and having the red fundus reflex.
Good point. Probably poorly pigmented fundus and a bit of a red glare there, so possibly not hemorrhage. I actually don't think there was hemorrhage in this eye, so forget what I said on that. I think Gillian's correct. All right, so let's do, it's kind of gooey. Subgross. So you can see that the lens in this case is essentially just like an empty capsular bag. This patient did not have cataract surgery. This is just a resorbing hypermature cataract, where most of the inside of the lens is now perhaps resorbed or possibly somewhat leaked out. We do have kind of attached retina and, I don't know, kind of a boring eye otherwise on subgrowth. But this eye is pretty spectacular if you start to look a little closer. So we can see from lower magnification that the iridocorneal angle is pretty sealed up tight. We don't really have any of that rarefaction from the ciliary cleft and tracheal meshwork. And if we look closer at what's actually crossing the angle here, has this very characteristic look. So we have these pretty hyaline discrete membranes, and then they're sort of alternating with these layers of low cuboidal to maybe spindle-looking cells. So hyaline basement membrane looking thing, cells, membrane, cells. It's this sort of alternating stacks. I like to think of this as like an opera cake effect. If you're also like a baking show fan, it's like a cake with thin layers of alternating cake and frosting. Anyway, in addition, this stuff is actually extending into the iris stroma. We have these little pouches of cells, often surrounded by a little bit of basement membrane. And then there's this structure here too, this eosinophilic globule, which if you're used to seeing cataractous lenses, is reminiscent of a Morganian globule. That effect of iris stromal invasion of this cell population is even better in this section. Let's walk along the iris here. Look at this. There are little lentoid bodies forming inside the iris stroma, little Morganian globule and bladder cell looking guys surrounded by layers of basement membrane. You can also see similar basement membrane and cells carpeting other surfaces. Here it is kind of along the ciliary body surface, a bit fragmented artifactually. And if you head towards the lens in the full section, you can also see these membranes both inside and outside the lens too. So basement membrane and cell layers crossing the outer surfaces of the lens. So this is actually extralenticular migration of the lens epithelium, and it's pretty extensive. And I don't think that I ever have seen, and I don't think anyone else had seen, this feature of these lens epithelial cells migrating into the iris stroma itself. We've seen them migrate quite extensively along the intraocular surfaces, but into the iris stroma is weird, and making these little lentoid bodies in the iris is weird too. So here's a PAS stain, which highlights these basement membranes lovely. Look at that. So this is confirming that we have basement membrane deposition associated with these migratory lens epithelial cells. You can see those little clusters of cells with their basement membrane invading the iris stroma. We can look at that really nice section over here too to see that iris stromal effect. Look at that. Wild. So little migratory lens epithelial cells laying down basement membrane in the iris stroma itself and along the anterior iris surface and so on and so forth. So the extralenticular migration of the lens epithelium in this case probably caused the glaucoma. And it's really unclear why some cases of lens capsule rupture, which this lens probably did rupture at some point. In fact, if we go over here, probably I should have just thrown on the PAS stain because it's much easier to see with that. But there's a little end of a lens capsule here, and then it's sort of regrown across the gap. And you can see the other end there. So there is a break in the lens capsule. It's unclear why some cases of lens capsule rupture have this really robust extralenticular migration lens epithelium and some don't. But we've seen it as a complication of cataract surgery, and in this case, just presumably a complication of rupture of the lens.
This dog wasn't that young, right?
Correctly. 5 years old, middle-aged for a dog. Yeah. And then one more thing, the snow on this patient. Let me see. Actually, right here is fine to go back here. So you can see in some areas there are these clear acicular, which means needle-shaped, so clear acicular clefts. And this is cholesterol. So a lot of that sparkliness inside the eye was likely cholesterol crystals, sort of free-floating. We get lenses that are chronically broken down that have a lot of this cholesterol associated, and we'll, for fun, call them glitter bomb lenses. You'll cut into them and they'll just explode with sparkles. Probably the cholesterol clefts were a big contributor to the sparkliness of this eye. So just a really unusual case of really robust extralenticular migration of the lens epithelium in a dog. There's that video again, because we can. All right, here are some key diagnoses. Any questions about this case? All right. Looks like we do have time for the second one, so we'll go through that too. Here's the gross view. So this is a 11-year-old neutered male domestic short-haired cat. The description on this case is really good, and I like the description of how surgery went. So in summary, periocular swelling and exophthalmos, but patient seems surprisingly comfortable. Some ocular surface stuff going on, corneal ulceration, intraoperative. Enucleation was very smooth and uninvolved until the posterior aspect of the globe was reached, at which time transection of the tissue resulted in a moderate amount of brown liquefied material that was suspected intraocular contents. Upon removal of the globe, the posterior aspect was noted to be obliterated. Wasn't me. I love that. By suspected neoplasm. And they took some extra pieces of orbital tissue out and were suspicious that maybe excision wasn't. Oh, wait, no, they were actually thinking that the orbit looked fairly clean, though, after they were done with the surgery. But essentially things came out in pieces and it was a complicated surgery in the back. Um, so here is our gross view of this eye. This is the other half of the eye, but it hardly matters because indeed, just as they described intraoperatively, the back of the eye is just obliterated by this tan tissue. So we can still make out an iris here, and we can make out a ciliary body, this sort of brownish tissue, and it's just totally carpeted and thickened and distorted by this tan tissue as well, lining intraocular structures, filling intraocular chambers, and just destroying the back of the globe. The sclera is just like gone back here. Um, we do have a little bit of eyelid coming in too, and a little bit of an off-center section of a cornea up here to help orient you. But mainly we just have distortion by this really extensively invasive tannish tissue. All right. Let's try our subgross. It's a big slide, so it's going to be tough. So we have our corneal surface up here, which has a lot of purplishness and crusting. So this is a really broadly ulcerated and desiccated and essentially kind of necrotic cornea. And then we have kind of pinkish purple tissue by histology. So it's kind of like a moderately cellular to highly cellular tissue, severely distorting the uveal tract. You can just barely make out like bits of ciliary body epithelium recognizable in the chaos. And then as we go back, no lens in our sections, and then here's that destroyed posterior globe. The sclera essentially just dissolves into this weird kind of pinkish purplish tissue. And then in particular, we'll take a closer look at this area where it gets quite cellular back here. A little bit closer in a second. All right. Yeah. We won't dwell on the cornea, but just pointing out the appearance of essentially corneal sequestrum. So there's no epithelium here. This is a broadly ulcerated cornea. And then the superficial layer of cornea here has a low cellularity, and it's kind of glassy and brightly eosinophilic, which implies that it's really dried out and or necrotic. And we can see that this really dense purplish band is actually just neutrophils that can't quite invade into this necrotic, desiccated beef jerky-like tissue too effectively. So this is the typical appearance of kind of necrotic and or desiccated corneal stroma, which you could call a sequestrum if you want, which doesn't happen to be brunescent in this particular cat, but such is the way of things. Often corneal sequestra become brownish in cats. Back to the main event. So this used to be iris. Essentially, the iris leaflet is roughly here, and it's really expanded and thickened. And we'll not spend too much time in this area, apart from to point out that a lot of the actual cells in this tissue are necrotic or degenerate. So it's hard to see what the features of these cells are. It's mostly just necrotic debris. But there's a lot of deposition of additional stroma in this iris. So all of these intersecting bands of pink are collagen that has most likely been laid down by a proliferative cell population, and then those cells died and kind of dropped out. So that gives us this thick iris that's mostly got too much collagen to it, and then a lot of necrotic debris besides. To see the nature of some of our cells, we can go back to this area here, and we can already see from low magnification that there are some friends popping out that look really weird. As we go closer, look at these cells. Pleomorphism, multinucleate giant cells. This cell, I'm pretty sure, has more than 200 nuclei in it. That's a lot. So we have these huge, just massive multinucleate giant cells, and otherwise just this quite pleomorphic population of maybe kind of spindle to polygonal cells, maybe sometimes round. So pretty pleomorphic population here. This is an interesting case. The most likely diagnosis in this case, apart from just calling it neoplasia, it's definitely cancer, is post-traumatic sarcoma in a cat. So we didn't quite get lens capsules sampled in our sections. A lot of cases of post-traumatic sarcoma, especially the spindle cell variant, which is kind of the classic variant that is of lens epithelial origin, should be coupled with a ruptured lens. Who knows what the lens is doing here? It might just be kind of buried in the chaos. But the thing that really clues us in, I think, to likely post-traumatic sarcoma, essentially spindle cell variant, is that iris that we were looking at earlier. These cells were laying down quite a bit of collagen. which is what we might expect lens epithelium that is going wild to do, much as we saw in our first case, or our case just before this one as well. So there's that. It is possible that this could represent some other form of sarcoma, including histiocytic sarcoma with this high pleomorphism and giant multinucleate cells, or something else, essentially, what you might call anaplastic sarcoma or something like that. I did do a PAS on this case to see if any of those collagen layers were basement membrane, which would be more classic of lens epithelium. You can see that Desme's membrane highlights pretty nice, that bright magenta of basement membrane. But the majority of the collagen that these cells were laying down isn't really basement membrane-like. So not exactly slam dunk for them being lens epithelial origin. I mean, maybe. Maybe you can buy that some of these are kind of basement membrane-like collagen. I don't know. I wasn't exactly convinced. So there's your PAS for you, though, so that you can see that we did it. So that's this case. A really pleomorphic neoplasm that destroyed the back of the globe, and probably a post-traumatic sarcoma lens epithelial origin. We do also get some cases of post-traumatic sarcoma, also presumably of lens epithelial origin, that are essentially referred to as osteosarcoma variant because they can actually create bone and or osteoid. At least didn't see any osteoid in examined sections of this case, but that's another situation where a lot of these multinucleate kind of osteoclast-like morphologies come in. But yeah, didn't necessarily see any convincing osteoid in this case. I think that's all I have to say. Essentially, post-traumatic sarcoma in cats can metastasize. Metastasis has been reported, but more often it's local disease control that's the issue, essentially extension back towards the brain or locally destructive behaviors. And extrascleral extension or extension into the optic nerve are negative prognostic indicators, as you might imagine, suggestive of a relatively worse prognosis. And this case, as you saw, extended past the sclera. So kind of a bad sign, unfortunately. That's it. That's all I have to say about this case. If there are any questions about either case, I can answer them. Good. Yes.
So just oh, go ahead.
Well, I just had a question. When you have an injury to the eye, are we more suspicious that you get a sarcoma, or like the other case with the lymphoma, is that more of like a chronic irritation?
Can you repeat the question?
So the question is, when you have injury to the eye, trauma with lens capsule rupture, like how often does it tend to be a sarcoma versus a lymphoma is what you're asking, essentially?
Yeah, basically.
Okay. So it's maybe slightly different pathogeneses, I think, is the thought, at least. So the classic spindle cell variant of post-traumatic sarcoma is presumably a lens epithelial origin. So you most likely need a lens capsule rupture for that to kind of get started. Because the lens epithelial origin, we get these migratory proliferative lens epithelial cells that maybe eventually undergo neoplastic transformation. With the ones that we call post-traumatic lymphoma or chronic uveitis-associated lymphoma, it might be a different pathogenesis, essentially, like similar to how our chronic uveitis or our chronic enteritis in cats or, chronic lymphoplasmacytic rhinitis, like that sort of thing could be like a pro-neoplastic environment that ends up with a lymphoma. So
To answer your question, the spindle cell variant is vastly more common
okay,
than
there we go.
the lymphoma variant. But overall, they're probably quite rare. But when you do have a traumatized cat eye, you should always consider, like, is there possibly something bad brewing in there?
That's actually answering your question. Yes, thank you, Gillian. Okay.
Just before we finish, just a quick reminder that in 2 weeks it's gonna be Christmas Eve, so we're not gonna have rounds. So we see you guys next year, I guess. And if you're out there, stay warm and drive safely.
Merry Christmas. Happy holidays.
Bye, thank you. Have a good holiday.
All right.
Was this dog's name Snowflake?
No.
Miracle with snow globe?
Yeah.
Don't stop recording.
Oh, yes. Just wait.
And